Yeah. Okay. Good afternoon, everyone. Today's date, 23rd January 2025. Good afternoon and my greetings to everyone. Welcome to the first session of 2025 POPMA's Study Club, and this will be the fifth session in the row as we started from 2024. So this time we will have two types of series. You know that POPMA is Practicing Oral Pathologists and Microbiologists Association. And I am the founder president, myself, Dr. Bhuvan Nagpal. Those who are new to this study club, so this is just an introduction. I am a practicing oral pathologist, and this was the initiative taken by to empower all the oral pathologists who are into the practice, be it clinical or histopathology practice. So from this year onwards, every month we will have two sessions. One will be the youngsters who have some experience ranging from 10 to 20 years, and one oral pathology stalwart series in which those who have experience more than 25 years. So welcome you all to this academic extravaganza, and today we have with us Dr. Saika Chakrabarti sir. He is a practicing oral pathologist, and we have our moderator Dr. Nidhi Jadhav ma'am. She is also a senior practicing oral pathologist. So now I think we can start with our uh, program, and over to you, Nidhi ma'am. Please go ahead.
Yeah, yes, sir. Very good afternoon, all the members of POPMA present here. It's a privilege to introduce you all about Dr. Saikat. Dr. Saikat Chakrabarti is a highly skilled oral and maxillofacial pathologist with, with expertise in diagnosis, treatment planning, clinical research, and managerial skills. He has finished his BDS from Sri Guru Ram Das Institute of Dental Sciences and Research, Amritsar in 2007. He finished his MDS in 2018 from Mahatma Gandhi Postgraduate Institute of Dental Sciences, Puducherry. He further finished his postgraduate diploma in hospital administration from Apollo Medvarsity, Hyderabad in 2011. He has also finished observership in head and neck surgical pathology at Tata Memorial Hospital in 2023. He has a proven track record in oral pathology and microbiology, where he dedicatedly works for early detection and prevention of oral precancer and oral cancer. He is a project leader with NGO Parivartan and GMCH 32 Chandigarh for DOST, which is Doorstep Oral Screening and Testing. He has very actively and voluntarily conducted talks on tobacco de-addiction and also raised awareness about COVID-19 pandemic and its related rehabilitation. He is an ardent blood donor and an active member of the Red Cross Society. He has a biopsy reporting center named Dentoscope running in Panchkula since 2018. He has played excellent roles as lecturer and dental consultant in various renowned hospitals and institutions with multiple research publications and presentations at various forums. He has done workshops on diagnostic innovations, IHC, and fluorescent microscopy. Today, sir will be presenting his lecture study club on clinicopathological correlations of oral lesions, a diagnostic workflow. It is a great honor for us, sir, to hear from you today. So may I request Dr. Saika to please take over and start with the presentation. Dr. Saika?
Yeah, thank you. Am I audible?
Yes, sir, you are audible. Yes,
clear?
sir.
Fine.
Yes, very clear.
Yeah, would you all like me to keep my video open, or should I just close it and go ahead with my presentation? Bhuvan sir, आवाज नहीं आ रही.
You can go with your presentation. After that, we'll come up with the Q&A session. So that will be fine. And
so I'll switch off my video right now. Audio will be on.
Yeah.
Yes,
Oh,
the
no,
screen
sir.
will not
You
be
can
seen,
keep
otherwise
your video on, sir.
अच्छा अच्छा
You can keep your video on. We will turn our cameras off.
ठीक है
Okay.
ठीक है
Okay.
I'll start
Please
that.
go ahead, sir. I request everyone to keep their mics and cameras off for the session, and afterwards we can have a Q&A, and you can keep on posting your questions in the chat box. Thank you so much.
Thank you and good afternoon, everybody. At the outset, I would really express my gratitude to our own organization, POPMA, uh, the members of the POPMA Study Club who have given me this opportunity to talk to all of you. I welcome you all, and once again, thank you, everybody, to join in this session. A special mention to Dr. Nidhi Yadav for such a beautiful introduction of mine. And of course, Dr. Bhuvan Nagpal, who have provided us this platform to talk to you. Um, in today's lecture, primarily it's not a lecture; it's more of a talk. The presentation would basically highlight on how an oral pathologist would take up the role of a clinician or a diagnostician when she or he is practicing in the private in the private practice of dentistry. Because most of the times this lecture would be a slight detour from the normal oral pathology lectures, where the normal oral pathology practice happening is in colleges, um, where the clinical part of the lesion, the oral pathologist gets to see only when the lesion is dipped in the formalin. But when you're practicing in private, there would be instances when the clinician will send the patient to you. So my presentation would really highlight on what should be the clinical workflow to diagnose a lesion when a patient walks into your office with a lesion in his or her mouth. Clinical knowledge of the lesion is very important. This is just to highlight the fact. If I show this picture, histopathology picture, to all of you, and there is hardly any clinical information which is coming with this. The only thing would be, now if I ask you to take a guess. So this is thick keratinization with prominent granular layer, but I won't really know whether people are interacting with me or not. Anyways, thick keratinization with prominent granular layer. What, which kind of lesion it would be? Now, there is no clinical information. Let's say the clinician has gone off to a holiday and right now he's in flight. There would be instances when you would get such cases. History is coming, we'll give it to you in WhatsApp. So if this is the lesion, most of us will will take a guess on any kind of a skin lesion, maybe.
Good, Achan.
Anji, can I continue? I guess I can. So most of us will think of any kind of a skin lesion. Now, this is the history. It is a cystic tissue which is obtained from a 3/8 region, and 3/8 was non-eruptive. This case was actually orthokeratinized odontogenic cyst. So now here is the difference. When you observe a particular lesion clinically, when you know the clinical picture of the lesion, you get to know what are you expecting to see under the microscope. So basic things. Once we get a lesion, we need to categorize them into some kind of appearance, whether it would be an ulcer or whether it would be a patch or a macule or whether it would be a plaque. We all know the definitions, how the things look. This is an ulcer, right? Local loss of epithelium. This too is an ulcer. There is a difference. There is a difference in the clinical presentation. There is a difference in the way the ulcers look. The one which is in this ulcer is accompanied by a erythematous halo around the ulcerative area, where in this case it is not. The history of this ulcer would be around 7 days. The patient is a young 12-year-old female. Here, the history of the lesion is around 5 to 6 months. So this is an acute lesion. This is a chronic. This is an acute ulcer. This is a chronic ulcer. So things change here. This is the time when you just open the mouth and looking at the a lesion, and then the things start happening in your brain. Okay, fine. This is an ulcer. I'm categorizing it into a chronic ulcer or a acute ulcer, and now how do I proceed further? Patch or a macule. This is a patch, reddish white patch. This too is a patch. Very telltale sign. This is the lichen planus. This is an erythema. कोई बोला क्या? Is everything okay? I mean,
Yes,
can I continue?
Dr. Saikat, please go ahead.
Hmm.
Actually, in between, some people, the mic gets on. So please
Right. I'll
go ahead.
continue.
Don't bother. I'm
Right.
taking care of all that.
Right. I'll continue. Right. So if this kind of a presentation comes to you, we know that this is a patch. Now, whether it is painless or painful or what is the duration. Now, if we see it on the right side of our screen, it is a very telltale Wickham stria, which is there along with the blackish patch. So immediately we know the diagnosis that this is a lichen planus. Now we have to think that whether should we go ahead with the biopsy, is it needed or not. In this case, this patch, well, the patient is not aware of it and things like that. We'll see what else is there in the history or in the clinical presentation when we are looking at these kind of patches. But then this will start giving an idea where we are going with the lesions. This is a plaque. Plaque is a raised area flattened on the top. Once you see these kind of lesions, again, you know, okay, this is perhaps a candidiasis. And what do I do next? What else should I know about the patient's history? So I would really advocate that whenever you get a lesion, the first thing is to categorize them into the way we have been reading in our oral medicine and radiology books. This is a papillomatous lesion. I'll apologize beforehand for a little offbeat photographs because we normally take it with our own camera um, on the patients. But if you can really notice this, it's a very papillomatous type of a growth. This is a papilloma. This is a papillomatous growth, painless, very slow growing, ventrum of the tongue, female, no habits. So these are the things which you already know when you are looking at the lesions, and now you start thinking whether should I go ahead with the biopsy or should I do other things to treat it? Because now you're not a histopathologist. You are a clinician who has to take the case to the conclusion. Annular growth, very typical of geographic tongue. This is an ulceroproliferative growth. We'll come to the part later. Well, where when we see an ulceroproliferative growth, what is the first thing that should come in our mind when we are planning a biopsy of it? So, clinical workup in the first thing would be pain. You need to ask about the pain. Usually, the chief complaint would be either I have pain in my lesion or I have burning sensation when I eat anything spicy, or it can simply be an incidental finding. Chances are we might get incidental lesions in incidental finding in our clinical setup because most of the dental surgeons working in the private setup are not oral pathologists, and their mind is not trained to see the lesions which is there in their mouth. So most of the times, if the patient is referred or if you're going looking into some other kind of a pathology, incidental findings will be the one which you really have to emphasize upon. So these are a few things when we are inspecting a particular lesion. Sight is very important. Size would help you decide what kind of biopsy would you do. Spread, color, mostly in cases of hemangioma or nevus, duration, whether the lesion is unilateral or bilateral. When we talk of pain, if it is painful and if it is tender on touch too, probably, and if it is an ulcer, probably we'll think of a acute onset ulceration. The patient would be young, then think of any viral etiology. You really don't have to go ahead and do biopsy in these cases. We know it will be a self-limiting condition. Symptomatic treatment for these kind of cases. Again, the same photograph. plaque. It's a patch or a macule. The telltale sign would be this thing, the Wickham's triad, and the patient more often than not complains of burning sensation. So now we know that this is an oral lichen planus. Normally, biopsy is not really mandatory in these cases, but yes, sometimes we need to observe if there is any proliferative activity. If it is refractory, if it is not answering to your pharmacological treatment. But any case, this becomes a OLP. When you are when a particular lesion is an incidental finding, your site becomes very important. For example, the lateral border of the tongue. Now, if you see this photograph, there is a growth here, and there are two almost decayed destroyed teeth here, 8 and 7, and you can actually see the sharp edge of the 8 over here. Now, if we keep the tongue back in the normal physiological position, we'll get to know that this thing has caused this very slow kind of a chronic ulceration that would happen due to the irritation from a sharp tooth. This is a sharp tooth. It can also be a malposed tooth. Again, we can actually see an indentation of the tooth in these cases. Here, lateral border of the tongue, one of the very important sites. In cases of any users, they normally use they keep the quid. Most of the Indians are right-handed, so they would actually make if you can see my video here, they'll mix the quid with their right hand and put it in the left vestibule. So this is the left vestibule, and now we can also see the changes. Again, left vestibule. This is a place where the canny is being kept. And if we really extrapolate this finding to the ultimate disease which these kind of lesions take, that is common cell carcinoma, then equating the fact that most of these lesions you would find in the left vestibule, lower left vestibule, is it also a fact that then oral cancer presentation should also be on the left side of the patient when it actually unfortunately turns into carcinoma? And that is the case. I mean, in GMCH and radiation oncology department 2022 data, when we looked into most of the primary tumor in oral console carcinoma was left-sided one. So this is the reason. So left labial and buccal vestibule in any case is very important area to examine, but left vestibule would usually be an area where you will find a lesion if the patient is in habit of any consumption. Any consumption, no other. I'm not talking of Gupta or Sarta or BD, because those are not the things which you place in the mouth. Retrocommissural lip. This is a very, very important area if the patient is a smoker. The retrocommissural lip is an area which would have some kind of changes if the patient is using smoke form of tobacco, BD, cigarette, or any kind. Usually, if we do not know this fact, then generally we'll miss it, because this is the area where we keep our instrument to retract the cheek or the tongue. I mean, retract the cheek. Now, if the patient has given us a history that he is a smoker, and if our mind doesn't know that we have to check the retrocommissure of the lip, we'll definitely miss it. So retrocommissure of the lip is another important site. Whether the lesion is in the multiple sites, we can see there is a lesion here, there is a lesion here. Again, this was a case of a proliferative varicose leukoplakia, multiple sites. When we see lesions in multiple sites, 2 or 3 things usually click in our mind. One would be a proliferative varicose leukoplakia, or probably am I looking into X disease? So these are the things which you need to keep in mind. Primarily, it is a violent-induced lesion. Okay, female non-smoker. The laterality of the lesion, whether the lesion is a bilateral lesion or a unilateral lesion. Lichen planus, I have mentioned there, usually is bilateral but metachronous. You might not get a lichen planus presentation bilaterally at that particular time. On the temporal span, lichen planus would come up in one side of the oral cavity, will heal up with hyperpigmentation, and maybe come up in the other side. So the patient usually, I mean, my patients, many of them have usually complained, I have seen a white patch on the left side of my cheek in the back area, and then after 2 3 months, this was, I don't know what happened to this, but the same thing was also happening on the other side. Yeah. This hyperpigmentation is a indication that these are healed lesions, because they normally, when the lichen heals, it heals with melanin deposits on our epithelium, so thus the blackishness. Now, once we are done with the inspection, we'll do the palpation, whether the lesion is soft. This was one lesion which was very soft in the palate. This was not. This was indurated. This was hard. Again, if the lesion is soft, like, I mean, if I give you this case, the patient opens the mouth and says, it is there in my mouth for 2 months. But then when we palpate, this is almost, it's very, very soft. And it has not grown in size, it is pedunculated. Now we know that we are not looking at some kind of a malignancy. Definitely a neoplasm, a tumorous growth, but definitely not a malignancy. Whereas in this case, things might get dicey, because this was a case which was indurated. So it is another one of the very important aspects of examination, that is the palpation of the particular lesion. Whether the lesion is scrapable or not, these are the lesions which are, this is a lesion which is unscrapable. This is a lesion which is scrapable. Now, when we talk of scrapability, unscrapable lesions will be the ones where the whiteness of the lesion is because of the change in the epithelial width, keratinization. Whereas if it is a scrapable lesion, it indicates, or it gives us a hint that some exogenous source has come and settled itself on top of a particular lesion. I've given this very prototype example of candidiasis, where this is nothing but candidal hyphae. So you can actually scrape the thing off, and then, because it is not a part of the change in epithelium, whereas in this case, it is a part of the change in epithelium, which is bad. This too is equally bad, because candidiasis will not inflict upon a person with a healthy mouth. Which means if it is this proliferative of candidiasis, we need to take a very detailed history and then examine the particular lesion after scraping off this canthal pseudomembrane. So now, if we collect everything together, risk factors. Now, these are the questions which should be there in our mind. This is the algorithm which would run in our mind when we are looking into a lesion. First of all, is there any risk factor involved when we are looking into a lesion? Is there any tobacco use, or is there any sharp tooth, crowns, malpose tooth, third molars? Usually, the lesions in the RNT, the retromolar trigon, the culprit would be a upper third molar in buccal version. So all those things. Duration. Any lesion in the mouth, any ulcer or a patch for more than a month. Generally, it is 2 weeks, but then let's do plus minus and keep it 1 month. For more than a month, even if it is a diabetic, yes, he should be a controlled diabetic. Okay. So if the duration of any of these lesions is more than 1 month, we should really put our thinking caps on that what are we looking at. Tenderness. The tender the lesion, the painful the lesion, happier we are. If the lesion is non-tender, if the lesion is painless, that is the time when we have to really put in our effort to see what again are we looking at. Okay. And if there is induration, then again, the things are going in a bad direction. Site, as I've already mentioned, there are certain vulnerable sites. The buccal vestibule, also known as the gingiva buccal sulcus, the retrocomitial lip, lateral border of the tongue. Unscrapable lesion is bad because, as I mentioned, unscrapability usually would come up because um, the whiteness or the redness is because of the change in the epithelial width. Sudden mobile tooth is always an ominous sign. Sudden mobile tooth, I mean, we cannot emphasize more on this fact that if any practicing dental surgeon gets a sudden mobile tooth, he or she should not jump onto extracting a tooth. At least take a simple RVG or an IOPA, and it would tell you what lies beneath that sudden movement. Even if you think that it is because of generalized or localized periodontitis, which is aggressive, please take an X-ray, take an OPG. Don't jump into extracting the tooth, because if it is something bad, then you are done in and taken in for task. So, putting things together, white or a red lesion in vulnerable sites for more than 1 month, bad. Plus, associated with painless or very minimal pain and induration, well, it is worse. There is no obvious etiology. You do not, I mean, you see a lesion, but there is no tooth which is hitting it. Plus, the patient is, as I mentioned, the patient has, I mean, the risk factors are there. Then again, it is bad, because if there is etiology, we know that there is a reason for this. If the lesions are present without any obvious etiology, plus there are risk factors present, we are perhaps looking at oral potentially malignant disorders. I really do not need to invest much into what is the definition and all, but these are some very common OPMDs which we see in our clinics. This is erythroplakia, red patch, white patch is leukoplakia, and there is mixed patch which is erythroleukoplakia. PVL, as I mentioned previously also, oral candidiasis, oral submucous fibrosis. Oral lichen planus, we are still debating whether it is a pre-malignant, or, I mean, OPMD or not. But for all practical purposes, let us keep it as OPMD as of now. But the scale is changing now towards the other aspect. So, if we combine everything, now once we categorize a particular lesion into all those things which we have talked previously, we should be able to come up with some kind of a provisional diagnosis, and also decide upon whether we need to take a biopsy or not. For example, an acute ulceration in a young patient with a history of 7 days does not uh, uh, demand a biopsy to be done. First presentation of oral lichen planus, I usually do not go with biopsy if it is this clear with becomes ties and all. And if it is not erosive, if it is erosive, then we might think whether are we looking at pemphigus or pemphigoid or things like that. Generally, the treatment of all these lesions get delayed because the ones who, I mean, I'm sorry to say this, but dental surgeons who do not have trained minds on lesions, the first thing they see when they see a lesion is um, prescribed triamcinolone. So triamcinolone will not act everywhere. Topical steroids do not act on OPMDs. Few days back, I mean, I don't know whether Dr. Vijay Banerjee is here or not. He had posted a very good picture, one of his cases in Facebook, that guy, when ultimately landed up to in Dr. Banerjee's lab, he or she had this big file of all the various dental clinics which he or she has visited. I'm so eager to ask that, have you ever? I'm sure that he must have seen that somebody has prescribed Canacon, because the moment they see that there is a lesion, the first thing is let's prescribe Canacon, and we'll see. Then we'll see after 7 days. The patient is gone by that time. Because let's remember one thing, there would be some kind of a minimal inflammation with all these kinds of lesions where Canacort will not work. But Canacort is a topical steroid which has an anti-inflammatory property, yes. So when you apply it locally, there would be some reduction in the inflammation, and the patient thinks I'm healing up. So and the doctor has called the patient back for review after 7 days. By that time, the patient is gone. When he again visits somebody else, ki, nahi, my lesion is not healed, I have used this tube which the previous doctor has given, the other doctor will again start from square one. So we should know where to prescribe Canacort. Lichen planus, yes. Erosive lichen planus is very good. But OPMD, no. Histopathology still remains the gold standard, we all know. So when we talk of histopathology, definitely clinically it is the biopsy. So when do we need to do a biopsy? When we are not getting any answers, um, when we are looking at the radiological or the clinical picture of the lesion. Um, Important point in this slide is the fourth point. Any inflammatory lesion that does not heal after 10 to 14 days of removing the etiology. For example, an ulcer comes to our clinic where we are able to see the particular etiology, that there is a malpose tooth which is hitting into the tongue of the buccal mucosa. So the first thing to do is to extract that tooth. And the day you extract that tooth, do not take the biopsy. Because if you take the biopsy in histopathology, we'll see nothing but lots of inflammation, and more often than not, that inflammation would mask the actual histopathological features of the epithelium, which would be in the background. So once the first thing to do is to remove the etiology. You remove the etiology, you remove the rounds, round off the sharp edges, extract the tooth, maybe counsel the patient to stop smoking, all those things, and then wait for 10 to 14 days and then come back to see whether the lesion is healing or healed or there is no change. If now there is no change, please go ahead with the biopsy. Why do we need to do the biopsy? Obviously, it gives us a final diagnosis. It helps us plan our treatment, confirms the provisional diagnosis. The only areas where we should not attempt to take a biopsy is there is no absolute contraindications, relative compromised systemic health, proximity of the lesion to the vital structures, and some anatomical variations. I mean, I have also got a case where the clinician wanted me to perform a biopsy on photiasis granules because he saw certain whitish, pinkish things in the patient mouth, and the patient was almost um, sure that he has developed a carcinoma, which was nothing but photiasis granules. So anatomical variations, no need to take a biopsy. How do we take a biopsy then? What are the types? Incisional, excisional. We all know about what is an incisional biopsy, what is a punch biopsy. Needle biopsy we usually don't do because oral cavity is so open to us. We don't really need an USG guided needle to go in there and do it. Incisional excisions are the ones which are the best. I have prepared a few slides on how to when to do an incisional and when to do an excisional. It is here the size becomes very important. The last point, I really vouch by this adjunct technique because it really helps us if we are planning an incisional biopsy. It really helps us uh, put our finger on probably the most representative site when we are planning an incisional biopsy. Here, I would really like to mention that there is still a debate on whether if you get an ulcer-proliferative lesion or if you get a lesion which you might think may turn out to be a carcinoma after histopathological diagnosis, irrespective of the size, should we do an incision or an excision biopsy? Many are of the opinion that it should be an incision biopsy because then if it turns out to be a carcinoma, the oncosurgeon would know where the primary lesion was. The people who think against it, their argument is that till we do not know, I mean, let's say we get a lesion of 1 centimeter, less than 1 centimeter, and we do not know whether the lesion is carcinoma or not. There are all the telltale signs present in that particular lesion. I mean, it is indurated. The lesion is there for more than 1 month in the patient's mouth. Now, what do we do? We still do not know whether it is a carcinoma or not. It might turn out to be a simple dysplastic lesion. They go for excisional biopsy. So this is one thing where we still need to study. I normally advise to go on incisional biopsy so that if it turns out to be a carcinoma, oncosurgeon should know where the primary tumor is, so that now he can plan his incisions to take on the safe margins in a better way. Adjunct techniques generally we have copied all these techniques from the gynecologist basically. So these are the principles on which we work. Um, Acetovite is the chemiluminescence method is the one which the gynecologist uses to screen the carcinomas, the cervical carcinomas. So we use the same thing in the mouth. I mean, this is the picture which I have taken from Google because I don't use it too costly. If there is a dysplastic lesion and we do an autofluorescence, I think some name I've. If it is a healthy tissue, apple green birefringes. If it is not a healthy tissue, there are cells proliferating or probably a dysplasia. It will look black. I do not have any photo of chemiluminescence. This is my photograph, which I use it. That is phytostaining with toluidine 2. The same lesion, if you see here, We do a toluene blue, we do a counter staining, and now we see a very deep blue retention, the deep blue hue retention in this part of the lesion. Now it tells us two things. One, it is definitely a lesion which has proliferative activity going inside, so that is bad. Number two, if we are planning a biopsy, which we should, this area should be included in the biopsy. Histopathology should be able to visualize this particular area under his microscope. Again, there was a lesion. If we go back to whatever we had discussed in the previous size, let's say this was indurated. The duration is around 3 months. We are planning an excisional biopsy. This is what toluene blue will do for you. It will clear cut. There's a clear cut demarcation of how we are going to plan the incision, how we are going to take the lesion out. This is the excised lesion for you. This came out to be squamous carcinoma. Very telltale sign. Now, if I go back actually, now if we have taken this lesion out, there will be a suture or something. Oncosurgeon, this is a practical difficulty which usually happens. That if we take this thing out, now how would the oncosurgeon know? But they would still figure out how to place the incisions in the safe margins. So, anyways, this is to underline the importance of toluene blue. A 50 paisa coin size incision. The greatest diameter was around 1.5 centimeters. There is a very interesting backstory of this patient. She's a physiotherapist, and the lesion was here because there were two teeth. This is the left side. So 2.8 and 3.8 both were hitting onto this part of the tongue for the past 2 years. The first thing the dental surgeon did in some other tongue, they extracted both the teeth but did nothing to whatever growth was happening in the tongue. For 1 year, this patient kept on going to the dental surgeons, saying that the lesion is not completely healing, and they kept on giving Kenacort for 1 year. There are two dental surgeons in the family of this patient. Finally, after a year, this lady landed up with us, and the first thing we did was toluene blue. Now we can see this is the full stain, and then we do a counter stain with 1% acetic acid, and now you see that from the healthy area, the stain is gone, but it has retained in the part where the activity is there. This is the area correlating. This is the area. Now I know that the maximum retention is in this part. So if I'm planning an incisional biopsy of this area, this part has to be included in the incisional sample, and there are very less chances I actually miss the representative section. This also turned out to be a squamous cell carcinoma. And the first thing this lady asked me was, what was my fault? I kept on going to the dental surgeons for 1 year and still I'm here. So very typical mitotic bodies, tripolar mitotic bodies over here. And this was a clear-cut squamous cell carcinoma. Now the patient is treated. We are happy. I think this was stage 1 only. So before we decide to now take a biopsy, these are the tests which you should never miss. Biopsy is not to be done on the same day when the patient is presented with lesions. However healthy the patient looks, please go ahead and do these tests. And I vouch by each and every test: CBC, RBS, ESR, CRP, triple viral markers, definitely, and INR. Even if the patient is young, even if the patient you feel is completely healthy. Usually in carcinomas or immune-related diseases, ESR generally goes up. CRP would give you an idea of any kind of a impending infection if it is there. CRP generally rises when there is an exogenous source, some bacterial, fungal, viral infection happening inside the body. Where CRP, the C-reactive protein, will go up. Anyways, if you're ordering these tests before even if you're taking a very small biopsy, please go ahead, because you're dealing with blood. Go ahead and get these tests done and make sure that all these tests are within the normal limits. Basic set of biopsy, nothing much over here, PMTs and scalpels and tooth. I usually keep both the forceps, tooth tissue forceps, as well as the normal without tooth tissue forceps. Now, if we are practicing in private setup, now this is not entire exact. This slide is not basically for the oral pathologists because we know the importance of formalin solution. But if you are in private practice and if you are running a histopathology lab, or if you're planning to do run a lab, please make sure that you teach all the dental surgeons in your locality, city, probably in the rest of India, that except for formalin, there is no fixative which will actually fix the tissue. I mean, once you are in the market, you get to know what people think of fixation as a thing. I mean, I have got telephone calls from the surgeons that we do not have formalin. Can you send formalin? I said, okay, it will take around half an hour. Then they'll say that no, the tissue is already out. We have already performed the biopsy. Now, various kinds of things they will come up with would be really funny. I cannot really. I mean, this is beyond the scope of this presentation. I mean, I have got people who have told me that we'll send you the tissue kept in patient's mouth because that is what we do when there is an avulsion of the tooth. And then somebody came up and said, "Okay, we'll send it in normal saline." No, normal saline is not a fixative. Patient saliva is not a fixative. Whiskey also is not a fixative. Somebody told me that at the end of the day, you need alcohol. Now we'll send it in whiskey. So those are the things which are not fixatives. They really create havoc if anything else other than formalin is used, and then problem then lands up on our lab as histopathologists because then we know that seeing these slides we will not be able to give a proper final diagnosis. Formalin is something which you should teach everybody to use. Open top bottle. Normally, this kind of a bottle will come in 36 to 38% formaldehyde solution. We normally dilute it 3/4 tap water and 1/4 of the formalin. And then this is normal. I'll go through it very quickly. No need of lock. Field anesthesia normally works. One of the very good incisions would be a crocodile eye incision. And then you take the tissue out. And crocodile eye incision, this kind of an oblique incision would help you really get a good primary closure there. The tissue is out with you in the formalin. If you get a swelling, in the swelling, I mean, we diagnosed this clinically as mucocele and then a very soft incision above. And then you go ahead with the blunt section. The mucocele would be out. And again, you get a very good primary closure and very telltale histopathology picture of a extravasation mucocele with mucophages and all. So this is how you give a complete closure to a particular case when you are acting as a clinician as well as a diagnostician, and histopathologist in the private sector. Again, the same case. In palate, take the tissue out. You do not really need to put a suture because you won't be able to, and no need to free the tissue. Just leave it as such. Generally, in these cases, I tell them to apply that Dolagel CT, local anesthetic solution. Treat it as an ulcer now. The patient would be fine by 2 or 3 days. This was a fibrolipoma, soft, as I mentioned before. When you decide to do an incision biopsy in these kind of cases, incision, it is good to have this kind of a wedge incision where you do this incision on the healthy tissue first, followed by this one. Because then there is a concept of cfDNA going into the blood. I don't know how far practical that is, but I practice the incisions like this, that the first incision should be in the healthy margins. Once I go through the lesion, then that particular scalpel should not be touching healthy. I try that scalpel now should not be touching the healthy mucosa. Then you do the blunt section, raise the tissue, and then cut it from. Multiple tissues should be tagged. We all know this. When we do a exophatic lesion, as I was mentioning before, when we see an ulcer proliferative growth and we are planning a biopsy, the first thing we should know is please go deep, because that is the most common fight between the one who is performing the biopsy and the one who is giving the report. When the report comes, superficial section, please go deeper for the please go deep for the sections, and then they will call back and say, we went deep. How much deep do you want us to go to? So if you get a exophytic or ulcero proliferative lesion really proliferating out of the normal level of the epithelium, please go deep. The general idea would be that if this is a plate, the level would be around 1 millimeter. So now you know where is my normal tissue and how far deep do I need to go. And bleeding is really not a very good. I mean, somebody said once we get the bleeding, we stop. No bleeding, because also proliferative lesion will have the connective tissue going along with the part which is proliferating out. So you cut here, you get a bleeding, but you need to reach the main connective tissue part to get a proper good amount of tissue so that the histopathologist gives you a proper optimal final diagnosis. So if there is any non-oral pathologist in the audience, this is for them. That how do you interpret your results? Because okay, low grade dysplasia, what do we do? We do nothing. If there is hyperkeratosis, you do nothing. Many a times the clinician gives my phone number to the patient. He talk to the pathologist, and then he will tell you what you have to do for the future. Now we don't know. So now, if you know how to interpret your histopathological terms, you should be able to guide your patient through. High grade dysplasia or a severe dysplasia, you refer to a higher center. And if you need a deeper biopsy, then you need a deeper biopsy. There is no fight over it. So these are some of the cases which I was wanting to highlight. Why histopathology is always important? As I told you, this was a lesion which I had discussed previously also. Now see, this was the lesion, around 6 months duration. This was indurated. There is a evidence that it has probably come up because of some kind of a irritation from the adjacent tooth. We do a torting. This is the area which we must include in our incisional sample. You're confident this will come out to be a carcinoma, but it came out to be a moderate dysplasia. We went ahead. The rest of the area was cut. After 2 months of follow-up, the patient was completely fine. This I had already told. This actually we didn't think would come out to be carcinoma, but it came out to be a squamous cell carcinoma. That is why they say whatever you do clinically, histopathology is very important. Whenever you remove a tissue, do not throw it into the dustbin. This is the importance of histopathology. Histopathology, why histopathology still is the gold standard. And this was a very interesting case which we got. Some erosive lesions in the upper vestibule, and the patient has been given all kinds of steroids and everything, and he was not healing up. Finally, it was decided that biopsy should be performed, and I was called into the picture. This is a past staining. This was histoplasmosis. So we went ahead with the antifungal amphotericin B and stuff, and now you can actually see a good pseudomembrane forming over here, and the patient was in healing phase. The patient actually healed up quite nicely. Now the thing is, if we do not perform a biopsy here, most of us would think probably we are looking at peptides or some kind of an immune-mediated disorder. And what will we do? We'll give topical corticosteroids that will actually worsen the condition. So after amphotericin B, the patient was quite fine. Again, this was that candidiasis case. We removed this thing, and there was an erythematous area stretching from the RMT almost till the retrocommissure of the lip. We took two tissues, one from the posterior aspect and one from the anterior aspect, because the lesion was really long. We did toluene blue, and based on the staining, we took two tissues, anterior and posterior. The posterior tissue was like this, bulbous retipex and all those things. Perhaps a severe dysplasia, we thought so. And then the anterior margin was like this. Very bad. We can actually now see that the maturation pattern has gone for a toss with lots of inflammatory infiltrates in the connective tissue. We had no doubt that we are looking into a carcinoma in situ. And then we had a wide local incision. The patient was fine. At least we stopped the lesion to develop into a full-fledged, full-blown squamous cell carcinoma. This was an interesting case which I wanted to highlight, and then probably we'll wind up. 18-year-old male patient, missing 3738. I'm sorry, missing 3738. OPG was taken, and there was this lesion over here. Now again, differential diagnosis was this: tentative cyst, OKC, glioblastoma, the giant cell tumor. The thing is, the surgeon planned and to perform an incisional biopsy on this particular lesion. Now, the surgeon opened up, and usually we say that you should always send it to one center. But the surgeon took the tissues from the two different areas. I think one tissue was taken from here and the other tissue somewhere from behind, but two different locations. And it was sent to two different centers. Usually, we completely discourage many of the surgeons. What they would do is they'll take out the tissue and divide it into two parts and send it to the two places. This should not be done. I don't know whether you can do this or not, but then it was done, and we were trying things out. So center 1, center 2. So center 1 got the lining. Center 2 did not get the lining. Center 1 reported as, center 2 reported as, it was my center, cystic odontogenic lesion. The center 1, which was some other center, reported it as odontogenic keratosis. Then the whole thing was opened up, and now this time it was sent to only one center. Because now the surgeon was completely against the idea to divide this into two parts, because he said that once I've taken the tissue out, it will go to only one center. I was lucky enough to get the complete thing. Now the tooth was also there, the lining and everything was there. This was the complete thing. Typical unicystic glioblastoma, subepithelial hyalinization, reverse polarity, and then we got the follicles also. So the final diagnosis was unicystic glioblastoma, mural, luminal, and follicular. So here again, the last line is very important. In hospitals and in dental colleges, things are fine, because the one who's performing the surgery and the one who's giving the histopathological diagnosis would probably be 1 or 2 blocks apart, or probably be 1 or 2 floors apart. But when you try to replicate the same thing in the private setup, sitting in your clinic, the things would be twofold difficult. As I mentioned before, even to get I was lucky enough to work with this center, which really does very good pathology, the Vimal Kalia Center in Panchkula. They do a very good pathology, and one of the oral surgeons who always asks to show them the slides, the important histopathological slides, if there is an interesting case. But other than that, these are the things which you face, that we can send you the tissue uh, in whiskey, and probably one center where I gave a diagnosis of squamous cell carcinoma actually was quite offended that we wanted to put an implant and you now gave a carcinoma. So in private setup, things are twofold tricky. So always make a protocol and follow that protocol. Stick to those protocols when we are into the referral services in private practice. So I'll conclude by saying that mucosal lesions are very important, because not only locally, sometimes the mucosal, like for example, lichen planus. Lichen planus is actually a systemic condition. Fine, and the only presentation, the clinical presentation, might be the oral one. If we miss this, we are missing the systemic health of the patient. Now, if we miss a leukoplakic patch and we go ahead and do something, filling or an implant or whatever we are doing, and then that leukoplakic patch turns into a cancer, what to do next? So these are the things which we have to keep in mind whenever you see a mucosal lesion along with the other lesions. Mucosal lesion should be the one which should be treated first. This is the last slide, and I would really like all of you to just read through it, because this is one of the best sayings which I was able to put my hand onto. That what should be the mindset of a pathologist? I mean, I'm expecting everybody in the screen, if they're reading it. And I really like this line, that a mystic perversion of the assumption prevails among clinicians who believe that the pathologist, given only a piece of patient's tissue, has all the other ingredients necessary to produce a statement of absolute truth at the end of his report. It never happens. It never happens. That is why we need a pathological correlation. We need clinical pathological algorithms. And we also should point fingers at ourselves, that even worse would be a pathologist who thinks he can do it. So by saying that, I'll put my case to rest, and my respect to my professor at MGPGI, Dr. V. Ramesh, and this is my workplace where I sit and do all my diagnosis in the colors of pink and blue. And thank you everybody for a patient hearing. I think I'm done. Any questions?
Yeah. Thank you so much, Dr. Saikat sir. It was indeed a very informative session. Your words were not only informative, but they were transformative also. I believe that it will have a profound effect on all the listeners. And yes, very rightly said, the take home message is that the biopsy part is very much mandatory, because I have seen many cases referred from the dental surgeons, the general practitioners, and they keep on giving the treatments which you have said. And I must tell you that you should aware, all the listeners should aware to all the general practitioners, that if they miss any lesion by chance, that person can sue them in the court of law. As a medical legal consultant, I want to highlight that this point should be informed to all the general practitioners. If they are missing any lesion on clinical examination, the patient can sue them. And again, I advocate that please do not accept any biopsies other than formalin. The fixative, the choice of fixative is formalin. Please do not accept. You will miss any morphology. It's always, don't be greedy at that time for 1,000, 2,000, 3,000, 5,000 rupees. Just tell them. And it is our unity when you tell them that we will not accept anything other than formalin. You provide them. Tell them that whenever you want to start a biopsy, please keep the things ready. Like before doing any surgery, they keep the scalpel, they keep that their tray, their sutures, everything ready. It's not like that that time they keep on searching. So why this point of giving the specimen in saline or LA or without that? That is not acceptable. One more thing I would like to highlight to all the listeners, as sir has said, that the biopsy specimen, they think it is like a blood. No, the biopsy specimen which is taken from a particular site will belong to that only, and should always be reported by a single pathologist. If it is reported, if they take two different sites and send it to like that, again you should inform surgeons, please do not do that. You want any opinion after that, take, you have to tell this thing to the surgeons very firmly. And I have tried this thing, the intentions and your work. So two you can always ignore. So yes, rightly, the biopsy is the choice, and histopathology is the gold standard, and should be implemented. Give whatever reasons, be it legal or be it a proper diagnosis or final diagnosis. So that's my take. Now, I think Dr. Nidhi ma'am, please take up any questions if there. Anybody would
I think
like
Dr.
to take
Nidhi
up,
herself has
ask
asked a
any
question
question?
about, ma'am, Nidhi
Yes,
ma'am.
sir. Dr. Kiran has asked a question. How would you rate cytology as a screening tool over a biopsy procedure?
Yes.
No, biopsy is not a screening tool. Cytology is. Biopsy is not a screening tool. So, yes, we can discuss about whether toluidine blue is a better screening tool or a cytology. I would still say cytology is a better screening tool, but you should do it. I mean, nobody does it the way we advocate or advocate it, or the way we talk about it theoretically. But toluene blue is a very handy thing. It immediately would tell you something about the lesion. Um, but between cytology and histopathology, when you are sitting in your clinic seeing these lesions, I don't think cytology would really help, because the first thing, the patient will not pay twice. Secondly, you in any case will go for a biopsy. So rather take a small tissue and then biopsy is nothing. I mean, 2 days time when the patient is healed up. In that case, biopsy I would recommend, but as a screening tool, yes. If Because if you are planning to use cytology as a screening tool, you need many personals to do it. You need a one who actually takes a good smear and then fixes it, and then you need a pathologist. But if you want to do it in a massive scale in the population, I think Volume 2 also would give you equivalent results.
Additionally, sir, doing a toluene blue also helps motivate the patient also,
Oh
because he
yes,
can see it visibly right in front of him, something is wrong.
oh yes.
So,
This is a very good point which you have taken. Yes.
cytology part we will be able to see, but patient we will have to just verbally
Oh,
convey. So we should
absolutely.
always keep those toluene blue stains handy with us whenever required, because that is a very helpful motivating tool for asking the patient to undergo biopsy procedure if
I mean,
needed.
government has now put up all those carcinoma pictures on the tobacco products. Indians have not stopped using tobacco after seeing that also. So toluene blue, when you show the picture change, that look, this is your lesion, and here, this is the ulcer in your mouth, and now we have taken a picture of that blue thing that has retained in your mouth. That is when they actually, you know um, I mean, now they'll start listening to you, that okay, I now understand that the lesion in my mouth has is there because of my tobacco use. Please help me quit it. Otherwise, if we simply give an off-the-cuff statement, the patient will never be compliant enough to leave tobacco, because the moment he leaves your center, there are 10 people selling tobacco outside in the market. So um, patient education is a very important factor when you're using Colgate. Very right.
Sir, I
I
had
think
one question.
Kiran sir wanted to say something, sir.
Hello.
Yes, you are audible, Kiran sir.
Yeah. Sir, Saikat sir, it was a good explanation about your cases and all. I just wants to know, because nowadays many patients are googling their symptoms, and like they want to know more options regarding the screening, like apart from cytology and vitality staining, what you were mentioning. Like, is there any other simple screening tools we can just
I mean,
see
I
for
did not find anything simpler and cheaper than Colgate Blue.
yeah. Hey,
And
I this toluene blue is very simple, which we
Hmm.
can, but
Hmm.
still, sir, like nowadays they're just directly typing the things in the Google or somewhere in the internet, and they are just getting to know something more advanced things also. Like they just want to know, like if there is anything else we can do for them, or if there is anything other than
I don't
this.
know what are you trying to, because now, like, there is DNA ploidy and there are things like that.
Yeah, that's what actually.
But I don't know how far practical would that be in the setup. I mean,
Yeah.
DNA ploidy and then LOH, all those things are there, but I have I'm yet to see the practicality of that.
Okay.
I'm yet to see once they are convinced that we need basic screening is done. Obviously, you can do a DNA ploidy and LOH and all those things can be done.
Okay.
We have to really see in India how many people are doing it.
That's what actually. That's why I asked, like whether you are performing or.
No, not at all. I'm not even using. I mean, yes, somebody wrote Wellscope. I forgot Wellscope and Visualite. That was Wellscope. I'm not even using Wellscope. Machine of tool. Ultimately, the screening methods, all the screening methods which you use are nothing will preclude the need for biopsy. You ultimately have to do biopsy. They'll just tell you whether there are proliferating cells in that particular area or not. If there is a particular area where there are proliferating cells, but there is a reason for it, let's say a healing lesion, then it's okay. But If there is a lesion where there is no etiology and still there is a proliferating cell, that is the problem. Those proliferating cells might be dysplastic. So even if you use a 2 lakh rupees well scope or a 2000 or a 250 rupees bottle of a toluene blue, not, ऐसा नहीं है कि well scope will preclude the use of biopsy. Now we do not need to do a biopsy. Ultimately, it will tell you that whether you need to do a biopsy or not. That is the same information even vital staining toluene blue is also giving in cheaper rates. Yes, there is a learning curve. You need to fall back on the history, but then that is more amenable.
Okay.
Histopathology will always remain our sasta, sundar, and tikau method.
Yes, absolutely.
Okay. Abhishek sir, you want to say something? Dr. Abhishek Badrana sir?
Actually, there is a thing called screening tool and diagnostic tool. I think so. Dr. Kiran was suggesting that where you screen the patient and then direct them for a biopsy. So there are some things that are available. There is something called ORA scan.
CPX is also this or what?
Yeah, where it actually calculates the hemoglobin levels or the oxygen levels in the blood. It is similar to the this one, the logic of having a lot of cells with nucleus, where toluene blue says a lot of dividing cells are there. Here, a lot of ATP is required for a malignant tumor, so they depend on that. But still, as Dr. Saikat was telling that nothing is substantial, statistically significant is there, no? Is not there. You can only direct a person to biopsy. So if you are having, it's almost 3.5 lakhs or something.
Yes.
Those equipments and ORA scan and Visilight also, they're quite costly. Finally, they're all this one is talks about is the collection of cells over there. So if you look at it in non-invasive method where you want to motivate the patient and educate them, but your diagnosis should be correct. Even after ulcer will show up a lot of nucleus in the surrounding.
Yes. But
So
you should fall
in
back
that
on the
sense,
history.
yeah, visual examination followed by toluene. That would be an effective screening tool, Dr. Kiran, Shasta Tikau, and then direct them for the biopsy.
Yes.
This is my addition to the talk. Very well spoken, Dr. Saikat. I really appreciate it. Shows the work that you're doing, which is practically you're working on such specimens and trying to solve problems. Okay, great. Congratulations, Dr. Again.
Dr. Saikat, one more question which has come up from Dr. Vivek Gupta. Sir, can you throw some light on how to identify the area for biopsy, especially while doing toluene blue, and if a tissue stains or doesn't stain with toluene blue?
With and without toluene blue. I mean, with toluene blue, you
How would you mark an area for biopsy related to the lesion with or without toluene blue?
Without toluene blue, I mean, with toluene blue, is the gentleman here?
Yeah.
Can
Dr.
you come
Vivek
on
Gupta? Dr. Vivek Gupta? Can you put on your camera or mic if you want to
just the audio? I mean, the way I'm understanding
ask the
this
question directly.
I mean, the way I'm understanding this question is that with toluene blue, the area of maximum retention. I mean, the case where I showed the lateral border of the tongue, the retention of the blueness was not uniform. Somewhere it was a little less blue, somewhere it was dark deep blue. Take the dark deep blue section in your incision. That is when you are using a toluene blue. But if we are not using a toluene blue, then if we have to fall back upon the age-old telltale signs in the lesion that you take the area of the maximum induration. If the lesion is, I mean, soft and firm, take the firm area. If the lesion is soft, firm, and indurated, take the indurated area. I mean, that is without toluene.
Yeah.
Yes.
Okay.
So, Dr. Saikat, can you please turn off the sharing screen thing?
Yeah, I'll do it. Yeah.
Yes. So, any other question any viewer or listener wants to ask to Dr. Saikat so that we can...
Sir, I have one question. When we have a positive staining for a lesion, with toluidine blue, and we biopsy at the same time, because it is easy to encourage the patient if the patient agrees we biopsy at the same time. Does it further in any way affect our processing and further staining with HME?
No. Even if the moment you put it in formalin, after 1 or 2 hours, the stain is off. During the processing time, I have done it a lot of times. But with the stain, I have taken the tissue out. By the time the tissue is out after dehydration from alcohol, the stain is completely gone.
Do we have any other questions from any of the audience?
Okay. So I think we can. I'll just. Dr. Nidhi, can you have anything else particularly to say? Or
Sir's presentation was a very nicely framed outline of all the clinical presentations that we should follow as an oral pathologist, basic biopsy related information, and I am sure whoever is practicing, many a times we get like cases where the BD, especially our BDS surgeons, clinicians expect us to do biopsy. So sir's points regarding all those biopsy procedures were very basic and very nicely told. So I really appreciate sir for sharing all his experiences related to this. It was a very nice, indeed, very nice presentation. Very aptly and clearly explained.
Thank you so much, Dr. Saikat, for giving your precious time. I just want to highlight he is a very good friend of mine, and he presently had some issues pertaining to shifting and all, but still he could manage with all that stuff is a big thing. And lot of big round of applause for you, sir. And many good comments people have said pertaining to your lecture. So thank you so much, sir. We really appreciate your efforts. And
thank you, Dr. Bhuvan. Thank you so much for the opportunity. Thanks to all the listeners, and especially Dr. Nidhi and everybody. Thank you so much. Thank you, Dr. Bhuvan.
Thank you so much.
Yeah, and if everybody are there, we can have a picture together if they can switch on their cameras. And one small notification that we will have the oral pathology stalwart series on starting from 29th of January. Every month that will be there. So Dr. Dinesh Daftari sir will be with us. So I request everyone to attend. Today also we reached nearly 40 members. So it's a good achievement. Slowly our tribe will increase. And yes, I have already shared the link for joining POPMA in the chat box. So if everyone can switch on their cameras, we can have a picture. One small piece of notification that with the POPMA's representation to the PMO and to the Ministry of Health and Family Welfare, they have considered MDS oral pathology qualification to sign the oral pathology and oral histopathology reports. In that oral pathology, you can see our curriculum. There, all the things pertaining to the laboratory medicine are included. So it is you have to interpret it very comprehensively. Now we have to take all these things into the official documents. This has been decided in the minutes of the meeting. Now we have to get it noted, and soon whatever our mission is there, we will be able to accomplish that. Thank you everyone for your support. It is not at all one person's work, because all of you are there. So it has happened because
some challenges, I think so, from his side on the network.
Sorry, I think sudden glitch was there. I was not able to. Yeah, I was telling that it is everybody's effort. All the oral pathologists who are with us, they have helped it. The voice of oral pathologists has to be recognized. And thank you so much, everyone. So I think we can have a picture together, those who want to.
I think so, Vivek sir, your face is a little not clear. I feel background.
One more. Thank you so much, everyone, for attending today's session.
Yes.
So let us meet 29.
Thank you.